So there appears to be a difference between how we can achieve castrate levels of testosterone depending on what agent we choose, whether it's a GnRH agonist or an antagonist. But what seems obvious here is that we need a well-designed prospective study looking at cardiovascular outcomes. So I know you've been involved with something. Tell us more about that, Dr. Sullivan.
So, Dr. Gupti, you're absolutely right in terms of there are differences. I think what's been very tantalizing is the fact that these studies have shown that cardiovascular risk is markedly diminished. Yeah. And the question is, what do we do about it? Because again, everything was retrospective and we didn't really have data. So there is a trial called the PRONOUNCE trial. This is a multi-center, multinational trial that's randomized phase 3. It is looking at major adverse cardiovascular event, as we call MACE, and those are again defined as myocardial infarction, sudden death, angina, need for bypass, in patients with prostate cancer and who have pre-existing cardiovascular disease. So these patients are extremely well annotated, and they will be those patients who either present, for example, with metastatic disease, or patients going on to radiation where they need good local control and hormonal therapy, or it's felt that in the patient's best interest, hormonal therapy would be needed.
And these are high-risk patients.
And these are higher risk patients, absolutely. So patients will be randomized, as you can see here. And again, the recruitment process is somewhat comprehensive in the sense that every possible nuance of their cardiovascular history will be captured, including but not limited to cholesterol, triglycerides, and the like. And as you can see, patients will be randomized to first a loading dose of degarelix, which is per package insert, then monthly degarelix for a year, and then leuprolide every 3 months. The expected accrual is 900 patients with an interim analysis after 50% of anticipated cardiovascular events. So the endpoint is really the time from randomization to the first adjudicated major adverse cardiovascular event. There will be a composite endpoint, which is death due to any cause, including non-fatal MI, non-fatal stroke, or unstable angina requiring hospitalization. And as you can see from the secondary, there will be, of course, a component that will look at any other symptoms that are related to prostate cancer, progression-free survival, failure rates, and the like. I must underscore that this is not a urology trial. Yes, we're using degarelix and we're using Lupron. This is not this is a cardiovascular trial and not urology, in the sense that this is the first prospective trial that is going to answer a question: is there a substantial difference in terms of cardiovascular events using a GnRH antagonist versus an agonist? The second is this is the first time that one would be looking at biomarkers such as exploratory cytokines. And the third, it would be the first to really look at the immune system and the impact of hormonal therapy on not only immune cytokines, but also on the cellular populations, because we all do vaccine trials, we use Lupron rather indiscriminately in those trials, and we're really not sure how it modulates everything.
So it will fill a major gap in the literature.
Absolutely.